Good evening. Thank you very much for joining us. We're really excited to be here to talk to you about some of the evolving understanding of a novel biomarker, MET-altered non-small cell lung cancer. It's a relatively complex field, a lot to talk about, and we've got an excellent set of faculty here. My name is Jonathan Goldman. I'm at UCLA, where I'm in charge of clinical trials in thoracic oncology. To my right, Dr. Ross Camidge, professor of medicine at the Joyce Zeff Chair in Lung Cancer Research, the director of thoracic oncology at the University of Colorado Cancer Center, Aurora, Colorado, and Dr. Juning Lee, associate professor, Department of Thoracic Head and Neck Medical Oncology at UT MD Anderson in Houston. We have a few introductory slides. We have people in the room and also virtually. I would like to thank PeerView for the excellent support in putting us together. Also, we'll speak briefly about the Longevity Foundation providing meaningful support as well. AbbVie has provided an educational grant for the symposium. If you haven't already, there's a pre-event survey. Please fill that out. And your participation is really crucial, both in person and online. Please use your mobile phones to scan the QR code on the following slides, and you can send in questions. Virtual learners, the QR code should also pop up for you, or I think you have a direct access to enter questions and to respond to polls. So this is the login QR code, so take out your phones, please. I will be using this for a pre-event survey, answering polling questions, and to submit questions to us, which we'll be very happy to take.
Hold on, I got to take a picture of it first. I might win $50.
Don't let Ross win this. Someone else has to enter.
You've got to be in it to win it.
And you can join visit at the peerview.com 2026 MET Lung website. The slides and practice aids will be available. You can look on X, and the email is below. We'll learn today how to implement IHC and NGS-based biomarker testing to detect c-MET overexpression and other MET alterations to inform selection of optimal therapy in advanced non-small cell lung cancer. We'll integrate current and emerging MET-targeted therapies into treatment plans for patients with advanced non-small cell lung cancer harboring these MET alterations based on biomarker results, the latest evidence and guidelines, patient needs and preferences. Longevity has provided meaningful support, really giving the patient angle and experience through this process. And we'll be having some videos from a patient who is here with us, Maggie McCloskey. So thank you very much for your participation and giving us your insights. So we'll begin by talking about the biology of MET, and then later we'll get into Ross and Juning will talk about the novel agents in this field. I find that MET is perhaps to me, one of the most interesting biomarkers. It's active in many different ways across several different cancers. Of course, we'll focus on non-small cell lung cancer. So we begin with a question. And it's not an easy question. Which of the following statements best reflects current standards for assessing MET pathway alterations and guiding therapy in advanced non-small cell lung cancer? 1, MET exon 14 skipping mutations and c-MET protein overexpression are both tested via NGS and can be used to select either MET TKI or ADC therapy. 2, c-MET IHC overexpression is a reliable surrogate for MET exon 14 skipping mutations and can be used to select patients for either MET TKI or ADC therapy. 3, MET exon 14 skipping mutations are tested via NGS for MET TKI selection, and c-MET protein overexpression is assessed by immunohistochemistry as an independent biomarker for a MET ADC therapy. And an honest 4, I'm not sure, is also okay. Please scan and answer. All right, I think this is quite a sophisticated audience. It is a complex question, and we're going to really be talking about this. 3 is the correct answer, so bump that up a little bit more. We use NGS to find exon 14 skipping mutations to identify patients for MET TKIs and MET overexpression as a biomarker for MET ADC. Now we can go back. Thank you. We maybe jump to slide. So MET, I'll just speak a little bit about MET. MET is, the gene is on chromosome 7. It is a heterodimer, and when it's activated, it leads to homodimerization and phosphorylation and downstream signaling, which you can see at the bottom there in gray. Really many activities of cancer, cancer cell survival, motility and invasion, proliferation, cell cycle activation. The MET signaling is quite complex and interesting. There's really just a negative regulator. You can see it almost right there in the middle. CBL, CBL, is a negative regulator sitting just under the cell membrane. And this is ubiquitinated, meaning it's tagged for degradation when CBL is present. But we'll see that one of the abnormalities of MET is removal of that CBL binding site. There are several different ways that MET acts and that it can misact, that it can be dysregulated. So the activation on the left, the ligand for MET is hepatocyte growth factor, previously called scatter factor, HGF, and it leads to downstream signaling through a lot of different pathways, and it's part of why it's so important in lung cancer. Some of these pathways, RAS, RAF, MEK, for example, well known in many different tumor types, and probably part of why, if not the principal reason why, MET can act as a bypass tract when you have blockade of the primary driving force. There are a variety of different ways that MET can be abnormal, listed on the right there. Exon 14 skipping, which we'll talk about in a second, MET amplification, just extra MET genes, or MET overexpression. The exon 14 skipping or amplification can lead to overexpression, but you can also get overexpression independently, and that also creates its own poor prognostic factor and a possible target for therapy. There are rare MET fusions. This describes the different prevalence. As I said, skipping mutations and amplifications are relatively rare, important to look for, but in the low single digits, whereas MET overexpression is really at a different level here, almost a third of patients, and in some situations, even more. So this was the first MET exon 14 skipping patient that I took care of. You can see she had a left upper lobe hypermetabolic lung cancer with metastasis to her right hip. She was a little smoking history, but had a squamous cell cancer, which was a hint that she might have a driving mutation. And before we knew about these mutations, we did NGS testing and got a MET D1010H mutation. This is one of the benefits of NGS, is you might find something you didn't even know you were looking for. This patient began therapy with crizotinib and had a several-year benefit. The biology is listed here, probably a little small for you to see, but the genes have exons and introns. The final protein is made by putting together the exons. In this case, exon 14 is where that CBL binding site exists, and several mutations inactivate that part of the protein. Many of them take out that exon 14 from the final protein, but there are other ways, point mutations and other ways that exon 14 CBL binding site is inactivated. So to summarize, these can be point mutations, insertions, deletions, or deletion of the entire exon 14. There's a couple of the important sites. Y1003 is the CBL binding site, but D1010 is some of the mutations that we often see, as a patient I just listed. These are perhaps a little bit older patients, 70 to 75. We don't see a gender preference. There are some smokers, but also many non-smokers who get MET exon 14 skipping mutations. Most are adenocarcinoma. A little pearl is the sarcomatoid histology variant is more likely to have a MET, is especially likely to have a MET exon 14 skipping mutation. Like many lung cancers and subtypes of lung cancers, brain metastases are common. The bottom point, I think, is one of the important things to take-home points that NGS we're all very familiar with. Some platforms only do DNA testing, where you would have to know which mutations you're looking for, but RNA testing here is especially important. It's almost like a functional readout of the exon 14 skipping that you can see in the RNA protein, in the RNA transcript for the protein, that the exon 14 is missing, and that increases your sensitivity by about twofold for finding these mutations. Now move to MET amplification. Dr. Camidge did a lot of this work and really I think is I would say the foremost name in this area. And it's a challenging one because as opposed to there being a binary readout, there's a spectrum from low level to medium level to high amplification. Where this truly is acting like a driver is in a high amplification, where you have meaningful response rate to, in this case, crizotinib or other MET inhibitors. One of the other studies that Dr. Camidge performed was looking to see how often do you have other drivers. And it's a sort of a nice way to demonstrate that when you have high MET amplification, you often don't need another driver. That is the true driver of the cancer. We're also going to be talking about the development of MET amplification in tumors with other driving mutations, particularly EGFR, where it's most well documented. 20 to 30% of the time you can get MET amplification. Most of the talk about the therapies will be taken by Ross and Juning, but just since amplification is a relatively small part of this, we would briefly talk about crizotinib and capmatinib. Crizotinib particularly active in patients with high MET amplification. Capmatinib in its development strategy also looked at amplification, and it was a challenging part of the trial. They had trouble identifying what they wanted to call amplification. I think we would all agree that a ratio to the cytochrome 7 is probably the best real documentation of amplification, but they used a 10 times copy number or gene copy number of 10 or greater, and ended up being too challenging, I think, for further development. So crizotinib is a very reasonable go-to here, but you can often get capmatinib approved as well. I'll speak briefly about this, and then I think that Ross picks it up later. As I said, one of the most important ways that MET amplification enters our treatment of patients is in the resistance setting, particularly EGFR, but I think pretty much all of the driving mutations, when you have a good therapy for them, can develop MET amplification. I've certainly seen several ALK inhibitors, ALK patients that on ALK inhibitors develop MET amplification. Here you can see from the Orchard trial, the patients, one of the largest subgroups of patients that developed resistance to osimertinib were due to MET amplification in the purple on the right. Lastly, we're going to talk about MET overexpression. This is probably the form of the oncogenic form that's been best characterized for the longest. For many years, it's been known that this was a poor prognostic factor. These are mostly post-surgical series that patients with high MET overexpression were more likely to have cancer recurrence. But we also see in the metastatic setting, high MET overexpression is associated with a shorter progression-free survival and overall survival. This is more on that the higher MET overexpression, the worse the Kaplan-Meier curves look. There are several different series trying to characterize the settings where we see MET overexpression. It is frequently in the 30-35% range. That is too small for me to see. I hope that you can see it. But there are different. I think I may just go to the next. Oh, here, I've figured it out. So there's gender, male and female in the two purple bars. different locations of the world. There does perhaps seem to be a difference in parts of the world. Asia a little bit lower, North America a little bit higher. Whether this truly ends up being a biologic difference, I don't think is fully known yet. And then different characteristics, ECOG performance status, et cetera, not really selecting out subgroups of patients that are particularly more likely or less likely to have MET overexpression. This is by driving mutation. At the top, EGFR. If you have an EGFR mutation, you are more likely, not dramatically, but a little more likely to have MET overexpression. But that may increase over time. Below that, KRAS, BRAF, ALK, and ROS. ROS does stand out a little bit more than the others for having a high MET overexpression. At the bottom, we put together some of this information as for co-expression of these different MET alterations. If you have MET exon 14 skipping mutation, you are more likely to have MET overexpression. In this data set, it's listed as 100%. I don't, that's not been my experience. I think there are other data sets that don't show that, show that not everyone with MET exon 14 skipping mutations have MET overexpression, but there is certainly some correlation. Amplification also is associated with MET overexpression, but it's not a surrogate marker. You can have one and not the other in both directions. Different cutoffs have been used for MET overexpression. The strongest cutoff is the 3+ overexpression from immunohistochemistry greater than 50% of cells. That's considered high c-MET overexpression. You could call it intermediate, or other c-MET overexpression is at least 25% of cells with 3+ overexpression. This was an evaluation of local laboratory versus central laboratory. This has, I think, moderately good agreement. However, I do think that as the pathologists are really getting better and better at this, I think my impression is that we've got quite good agreement, similar to other immunohistochemistry markers like PD-L1, and we'll get to that in a second. These are some of the guideline recommendations for patients with adenocarcinoma, non-squamous carcinoma. Of course, biomarkers should include NGS targets like EGFR, RAS, ROS1, BRAF, but exon 14 skipping mutation, as we've talked about, and also c-MET immunohistochemistry is recommended. I think that probably a little bit too much terminology has been introduced here. So hepatocyte growth factor receptor, HGFR, is the same thing as c-MET, or sometimes just called MET protein overexpression. So don't be confused by that. In squamous cell, it is also recommended, particularly in light smokers. But I think we're now in a world where everyone should be getting NGS. And again, you'll be looking for some of these abnormalities. I would say it's relatively common if you have a non-smoker with squamous cell. If they don't have EGFR, I find they often have MET exon 14 skipping mutations. This is just a quick summary of the immunohistochemistry protein analyses that we look for in non-small cell lung cancer: PD-L1, c-MET, and HER2. They are all graded on the 1 to 3 scale. This cutoff of 3+ greater than 50% is unique to c-MET, so I do think that's a little bit of a learning point for pathologists and physicians and treating physicians. There's a follow-up question. Please take a look at it with your QR code, and then we're not going to take a moment we won't review the answers. We'll be going on to Ross's talk. All right, can we move on? I think for the sake of time, should we go to the video and then save questions at the end? Okay, so Maggie is here and on video, and we'll go to her video. Thank you.
Hi, I'm Maggie. I was diagnosed with stage 4 lung cancer in 2021. Prior to my diagnosis, the only symptoms that I had were vision problems, balance problems, and a partial DVT in my leg. I didn't have any sort of lung symptoms at all. When I got diagnosed with a CT scan, the CT scan found that I had stage 4 lung cancer. I knew about cancer. I heard stage 4. I thought that I would go on chemotherapy. I thought I would lose my hair, and I thought it would be gone by the end of the year. But I had my oncologist did a blood biopsy, and with the blood biopsy, I found that I had a targetable mutation, which was the EGFR mutation. I went on a targeted therapy pill, and I was still around by the end of the year, doing well. In the spring of 2023, I had progression, and this time, another blood biopsy showed that in addition to the EGFR mutation, I had a MET amplification. This was new to me, and it was explained that the MET amplification was preventing the EGFR TKI from doing its job. It was kind of circumventing the pathway and allowing the cancer cells to multiply. Fortuitously, there was a clinical trial that was starting at my cancer center for people like me that had progressed on an EGFR TKI due to a MET amplification. So I was able to get drugs for both the EGFR and the MET amplification, addressing those. In the spring of this year, I'd had progression again, this time a tissue biopsy. I had next generation sequencing testing on it, FISH testing, confirmed that the MET amplification was still there. So I went on targeted therapy, again, that addressed both the EGFR and the MET amplification. All of these decisions were made in conjunction with my oncologist. And most recently, with some progression again, I learned about IHC testing, and I learned about antibody drug conjugates, and I also learned that in addition to the MET amplification, I also had MET overexpression, which then opened up a whole new class of drugs for me. Like I said, the ADC.
Thank you, Maggie. You're in the room. That's why I said thank you. I didn't normally say thank you to a video. Okay, so I'm going to talk about some of the things you can do. Dr. Lee is going to talk about the targeted therapies, as in small molecule inhibitors. I'm going to focus more on antibody-directed therapies. But we're going to start with a case. So, 54-year-old male, ex-light smoker, stage 4 non-small cell lung cancer at diagnosis with lung, lymph nodes, skin metastases, but no brain metastases. They have a KRAS G12D, which apart from the fact there was a presentation on that today, we would generally think of as not targetable. First-line treatment was Keynote 189, carboplatin, pemetrexed, and pembrolizumab. And there was a response and there was progression after 9 months. The baseline biopsy had immunohistochemistry testing done. You can request it whenever you have access to tissue, and was c-MET overexpression positive, 3+ in 50% of cells. So here is your question. Please choose docetaxel, ramucirumab, telisotuzumab vedotin, capmatinib or tepotinib, a clinical trial, or you're still not sure. All right, and of course you're all brilliant. And the top two choices are capmatinib or tepotinib. You'll see whether that was the right or the wrong answer, and telisov. All right, if we can go back to the slides, please. So I'm going to talk about MET-directed antibodies. So the naked antibody, so just an antibody directed against MET, none have really proceeded. There are, for example, Lilly had one called emibutuzumab, which was extensively explored and then dropped. Various other companies had ones that we never took further along. There are also naked bispecifics. Amivantamab you'll have heard of is an EGFR and MET bispecific. And then you have sort of loaded antibodies. So anti-MET antibody drug conjugates, I'm talking about Teliso-V and its follow-on compound made by the same company called TMAB-A. I'm going to briefly talk about bispecific antibody drug conjugates, although they're very early in development. Okay, so let's talk about amivantamab. Amivantamab is an EGFR MET bispecific, which has several different labels. It's licensed for use with chemotherapy in the first-line treatment of EGFR exon 20. It's licensed for use with lazertinib as a first-line treatment for EGFR classical mutations. And it's licensed as a second-line treatment for EGFR classical mutations in combination with chemotherapy. And when you think about these things, particularly the last category, MARIPOSA-2, its use, and particularly its use of amivantamab together with chemotherapy, is going to depend on what you gave first. So if you gave FLAURA2 and you had a short interval, you're probably unlikely to want to give chemotherapy, although you can give amivantamab on its own. Here's the MARIPOSA-2 data. I'm going to concentrate on this just so we can focus on MET. So MARIPOSA-2 was chemotherapy plus or minus amivantamab plus or minus lazertinib after progression of an EGFR, after progression of EGFR mutant lung cancer on initial platinum-based chemotherapy. After progression, but without prior chemotherapy. And you can see that the amivantamab-containing arms were clearly superior to chemotherapy. They both had a mid-60s% response rate, 36% for the chemotherapy. And the median progression-free survival, again, was a smidge higher if you kept the lazertinib going, but not statistically significant. So that's why the license regime is actually chemotherapy and amivantamab without having the EGFR TKI going. It has surprisingly good intracranial control, and the top two lines, the blue and the red, are actually with and without lazertinib, with the amivantamab and chemotherapy. So although we normally have an opinion that keeping the EGFR TKI going might be one way of protecting the brain, it seems like amivantamab alone is doing that job. Now, yes, here's one of those tables you can't read, so I'm going to talk you through the side effects of MARIPOSA-2. There are the predictable side effects from amivantamab. You get a rash, you get paronychia, so EGFR-directed side effects. You get MET-directed side effects, hypoalbuminemia, peripheral edema. The other areas which I highlighted is that it also exaggerates the side effects of the chemotherapy. I don't think this is always fully realized, but nausea, stomatitis, vomiting are all worse than just the chemotherapy on its own. So you have to weigh that in. As I said, we have to weigh that depending on whether you got FLAURA2 first. So FLAURA2 is a common intensification regime for first-line treatment. And if you had it and you had a short chemotherapy interval, you would probably prescribe MARIPOSA-2, but just not give the chemotherapy. It's surprising. I've had multiple private practitioners call me up saying, well, they won't approve it, unless I give it with the chemotherapy. And you write the prescription for the chemotherapy, but no one's forcing you to give it. So if you're just using amivantamab on its own, what is the evidence it works? That comes from the Chrysalis study. It was somewhat stacked with MET-amplified and C797S EGFR cases, about 85%, so it is an enriched population, which in the real world you may not have. But it had about a 20% response rate in the monotherapy, as you can see here. One thing I want to point out is although in that EGFR mutant setting, it seems terribly attractive, you get progression, you're going to jump onto amivantamab or MARIPOSA-2 or something like that. We should recognize that there is heterogeneity in that acquired resistance population. And yes, MET might be a common mechanism. On-target EGFR mutations such as C797S might be common, but there are multiple other things that are actionable. This is actually a case where a RET fusion is a mechanism of acquired resistance. So although it's easy just to prescribe, I would still rebiopsy and reanalyze because you might be able to do even better. Let's talk a little bit about MET-directed antibody drug conjugates. So Teliso-V, telisotuzumab vedotin. Vedotin is an MMAE warhead, so it's a microtubule disrupting agent. Binds to MET, is internalized, delivers the toxin. There's also some downregulation of MET signaling, which is probably why you get, just like with amivantamab, some edema, some hypoalbuminemia, but not too much. In order to qualify for this, it's based on c-MET protein overexpression. using the antibody SP44, about 30% of lung cancer is positive at either the intermediate or high level, but only the high level is currently in the label. Got accelerated approval based on just the response rate in the high category, which represents more than 50% with 3+ staining. And in total, that's about 14% of lung cancer. Does it work? Well, look at the top row. So high had a 35% response rate, intermediate had a 23% response rate. That difference alone is why high is licensed and intermediate is not. But if you look at the progression-free survival, it is almost identical, 5.5 months PFS for the high group, 6 for the intermediate. But because for the accelerated approval it was based on the response rate, that's why only the high was licensed. In fact, they're so similar that if you overlay the Kaplan-Meier curves, you can see MET intermediate MET intermediate and MET high, the PFS curves completely overlap, as do the overall survival curves. What price are you paying in terms of side effects for these treatments? Well, peripheral neuropathy, corneal epitheliopathy or keratitis, some persistent anemia, and then about a 10% rate of interstitial lung disease, about half of which is grade 3. We're going to dig into each of those. So peripheral neuropathy is actually a surrogate for exposure. The median time to onset is 103 days. The median time to reducing the dose because of the peripheral neuropathy is 238.5 days. And when you look, peripheral neuropathy is associated with higher responses, duration of response, and exposure. My one clinical advice would be you monitor for this, you consider dose holding, dose reduction, as soon as you start to see sort of grade 1 or grade 2. And really the biggest issue is if you get grade 2 and you ignore it, it can snowball into grade 3 relatively quickly. In terms of the eyes, the median time to onset is a little quicker, 47 days. Mostly the patients will complain of itchy or blurred vision. And what happens is you're having microcysts formed in the cornea. They disrupt the tear layer. So lubricating eye drops are the solution. You don't need steroid eye drops, just lubricating eye drops. Teliso-V has accelerated approval, and therefore there's a confirmatory study called TeleMet, non-small cell lung cancer 01, which is Teliso-V versus docetaxel in both the intermediate and high categories, and that is still accruing. A quick word on some of the cohorts that were not part of the accelerated approval. So Teliso-V was tried in squamous lung cancer, which only had about an 11% response rate, so that wasn't pursued. In the EGFR mutant population, you can see here, although there was activity, it was pretty disappointing. 16.7% response rate in the high category, 0 in the intermediate category. Doesn't sound like anything you would want to give, although technically, per the wording, it doesn't say EGFR mutants are excluded. Even though the data was based on EGFR wild type, that's not in the label. What do I think is going on? Well, when you look at this study, which was led by my colleague Dr. Goldman here, this is what happens if you keep osimertinib going, your high or intermediate MET, and you add in Teliso-V. Now the response rates are not 10 or 15%, they're 50 or 60%. So what's going on? Well, we assume that MET is a mechanism of acquired resistance. If you're on the osimertinib, you're suppressing the MET negative cells. If you stop the osimertinib, those MET negative cells grow up, and they're not a target for Teliso-V. So if you choose to give Teliso-V, which I have done to EGFR mutant patients who have high MET expression, I keep the osimertinib going. A couple of other things about who might be more sensitive to this. Well, I think the best way to understand how MET as a target for an ADC works is thinking about when do we know the pathway is active. So if we know that pathway is active in signaling, it's very likely that it's going to bind, be internalized, and deliver the toxin. We've seen MET exon 14 skip mutations. We've seen MET overexpression, where you have to enrich for protein, because what you're doing there is you're enriching for the chances that pathway is active. What we see here is MET amplification. Even low-level MET amplification can really bump up those response rates. You can see running in the 67 to 100% range. Small number, but again, if you've got other clues that that pathway isn't just sitting there, but is actually active, your chance of benefit is even greater. I want to talk about the follow-on compound. So Teliso-V is made by AbbVie, so is Temab-A. It's the same MET antibody. The only thing that's changed is the warhead, which is now a diazatocan, a topo-1 warhead. Here's some data from the TMAB-A study. I'm going to show you information on the EGFR mutant cohort. So remember, monotherapy with teliso-V, I said, was pretty boring, 10 to 15% response rate. What happens if you give monotherapy with TMAB-A? You get a 63% response rate. Whoa. So all you've changed is the warhead, but it's much, much more active. It also raises a really interesting question as to how much better could it be if you kept the osimertinib going in this setting with TMAB-A, and those studies are ongoing. What price do we pay for TMAB-A, this new agent? Well, it's different. It has about a lowish rate of pneumonitis, about 7%. It causes some alopecia, although I say that's not prominent in my experience. It causes some stomatitis, again, low grade, not prominent in my experience. Mostly what you're getting is upper GI issues, nausea, vomiting, and anemia. It also works regardless of the mechanism of resistance. In those particular studies, this is based on cfDNA, you can see that there are multiple different on and off-target mechanism of resistance in the EGFR mutant population, and you're still getting really whopping activity. What's really interesting is in the EGFR mutant population, on the right-hand side, it doesn't matter whether you've got high or intermittent MET protein expression. The argument here is your a priori hypothesis that any MET is actually doing something in the acquired resistance setting is pretty high. You don't need to do this kind of slightly surrogate marker of MET protein expression. TMAB-A continues to be explored. It's being explored in the first-line study led by my colleague Dr. Lee in combination with osimertinib, and there are post-osimertinib explorations ongoing with and without the combination with osimertinib. What about the activity of TMAB-A in EGFR wild type? Well, remember we have teliso-V as our gold standard here, enriched for protein expression. We were getting 35-ish% response rate. Here we look here again, it's in a second-line plus population. What we can see is that fairly heavily pretreated chemotherapy and immunotherapy, there are relatively low levels of MET amplification. We have a 43% response rate, 48% response rate, and a progression-free survival of 6.9 months. So still good and clearly better than teliso-V. So teliso-V is likely to be one option. TMAB-A may be another option. Which one you'll choose first will certainly depend in the future. I suspect TMAB-A will eat teliso-V, but there may be options of using teliso-V after TMAB-A in the future. Interestingly enough, in the EGFR wild-type population, there is an impact of protein expression. So particularly clear over on the right-hand side with the red boxes. So if you have high-level MET expression, you have a 78% response rate. And if you're less than that, you have a 42% response rate. So still good in both categories. But why? What's going on here? Remember, this isn't an oncogene-driven subset. So you kind of have to prove that the MET is actually doing something, is actually active. And I think that's where the protein biomarker comes in here. The other study that's going on with TMAB-A is in combination with immunotherapy checkpoints in high PD-L1 in the first-line setting. The other adverse events, the AEs I was reading, the other antibody-drug conjugates in development are these bispecific antibodies. So you essentially take something like amivantamab and you stick a toxin on it. So AstraZeneca has one and Regeneron have one. And then there are other MET-directed ADCs in development and being discussed at this conference. Thank you.
Thank you. Maybe take a quick. Maybe take a quick moment. I'll just call out some of the questions just for a little something different. First one is about MET testing. How can MET overexpression by immunohistochemistry be integrated into the clinical workflow up front alongside NGS? I think this is a great question. We are currently in discussion for making MET overexpression testing, immunohistochemistry testing, part of our reflex testing, but we're still deciding internally. What have you done at your centers?
For me, we already integrated one IHC with PD-L1. So You say if you're going to be doing PL1 testing, you should do MET testing.
Yeah, I agree too. Especially now HER2 is obligated to be tested in the front line, so it makes total sense for both PD-L1, MET, and HER2 to be tested. There's still challenge of tissue. If the tissue is adequate, I still prioritize NGS, of course.
All right, and then for a fun question, what would the appropriate approach be for patients with co-occurring mutations in MET and another actionable alteration? I have mostly with MET amplification, but I think we've all used a MET inhibitor with an EGFR approach in patients with EGFR mutation and MET amplification. I've recently treated 2 ALK patients. What have been your experiences? Any interesting cases?
So MET always wins the best supporting actor Oscar. I mean, it is a very common mechanism of acquired resistance for targeted therapies. I think if you see it, we have traditionally, as Juning is going to go on and talk about, added in another targeted therapy. So whatever plus a MET TKI. I think now that we have these other tools directed against MET, I think that's just expanded the armor and Terrium. I'd probably still start with the TKI because just occasionally you get people who that is all the variation you've got in their cancer and you get really long control.
Yeah, I will add on to Ross's comment that if you do the dual TKI inhibition, the response rate usually is in the 30% range, and we get at least a few months of benefit. In addition, we do also have the CNS protection from both of the TKI, so that's also my preferred if the MET amplification is detected on top of other drivers.
Thank you. Juning, why don't you begin your section?
All right. So I will be talking more about targeted therapy, most on the small molecule inhibitor side. As Jonathan was already explained, that the MET can have at least 3 different ways to be activated, including genetically MET exon 14 skipping leads to the constitutive activation of the kinase domain, and overexpression as well as amplification are the other 2 mechanisms leads to poor prognosis. When we talk about small molecule TKI, the mechanism of inhibition is really dependent on the kinase domain activation because it's a small molecule fitting into the ATP pending pocket. So specifically, the TKI will be particularly good for genetic alteration, namely frontline MET exon 14 skipping and MET amplification in the secondary driver as a resistant mechanism. Small molecule inhibitors has, of course, generations of development. As shown here, usually is classified into type 1 and type 2. So the type 1 first is non-selective type 1 molecule is crizotinib as example, and insertinib is also another very good example. They do have other targeted therapy ability. For example, crizotinib is approved for ALK, and the insertinib is also approved for ALK fusion in China. The second generation of TKI for the MET is class 1B, so is more selective to MET. The ones that globally approved is capmatinib and topatinib, and in Asia, savolitinib and a few others also get approval for usage. Type 2 can actually overcome some of the known secondary resistance, but the problem here is overall type 2 inhibitor also have other toxicities related to the type 2 can cover a broad range of activation. Cabozantinib is used in other indication and sometimes is off-label used in the type 1B resistant cases for MET exon 14 skipping lung cancer. Currently, there are development ongoing for type 2 newer molecules hoping to introduce a higher potency as well as overcoming resistance MET inhibitor. I will be presenting at this ASCO at a poster about a newer MET inhibitor coming from Korea. MET TKI has established response as well as PFS in the last few years in the namely last 5 years. Showing here on the x-axis is the response rate, and the y-axis is the duration of PFS. I want to draw your attention to capmatinib and topatinib. Those are the two available in the US, and then topatinib is available in Europe as well. Those two are most widely used, the first two approved for MET exon 14 skipping. And I will go to the more data more. They are very good TKI inhibitors. However, there's still improvement needs to be done to improve both response, both PFS, as well as decrease toxicity. So here is the overall cross-agent comparison of the efficacy. As shown on the far left is crizotinib. As you can tell already, the response rate is in the 30% range, and then PFS and the DOR is 7 to 9 months. Initially, that's truly a game changer work led by Dr. Camidge and others, showing proof of the principle that MET exon 14 is a target. Subsequently, capmatinib and topatinib was evaluated in geometry model 1 and the vision trial. Here shows in the frontline setting, the response rate can be above 50%, and overall the response duration is about 1 year for both of the agents. Savolitinib is a newer agent developed in Asia, but I want to draw your attention that capmatinib, topatinib, and savolitinib, they all belong to class 1B. So they have slight difference in efficacy. However, switching around among those agents once resistance developed really didn't help patient, which was shown by a smaller scale clinical trial came from MGH a few years ago. As shown here, the waterfall plot really indicates majority of the patient derive benefit. The response rate defined by tumor shrinkage greater than 30% is around 50%. However, majority of the patients actually initially gets benefit. The duration is reasonable as in the frontline setting is about a year, but compared to some of the EGFR, ALK, other targets, we still have truly space to improve. This is a busy table, but I want to highlight because all three of the MET inhibitors, we're talking about capmatinib, topatinib, and savolitinib, they all belong to class 1B, so they have the class effect toxicity. The most pronounced toxicity is peripheral edema. Oftentimes, that's a lymphedema. Associated with that is the impairment of kidney function, sometimes transient, sometimes a little more permanent, and then decreased albumin in the because of the loss from the urine. There are ongoing studies trying to mitigate those very hard to treat toxicities for MET TKI. Clinically, I think we can all discuss how we help patients and help ourselves to continue for the patient to stay on the appropriate TKI. Oftentimes, we need to do dose reduction as well as drug holidays in between. Now we have FDA-approved TKI upfront. And then the debate oftentimes comes from patients who have competing biomarkers. For example, if a patient have MET exon 14 skipping, but the tumor also demonstrates high PD-L1, what will be the most appropriate frontline treatment for those patients to maximize their benefit? Although we all understand that we can sequentially use those medications. This is a joint effort between MD Anderson and Dana-Farber, collecting around 150 MET exon 14 skipping patients who had initial treatment at those two institutions. We found that MET exon 14 actually have a artificially higher PD-L1 expression compared to other oncogene drivers, meaning that 80% or higher PD-L1 was seen in around like a quarter or a third of the tumors or the patients. In terms of the metastatic site is distributed very similar to all the stage 4 non-small cell lung cancer. In this analysis, we separate the patient into frontline, they received immunotherapy plus minus chemotherapy, versus the patients who received the TKI in the front. Here is a real-world analysis so that the frontline treatment is a little more heterogeneous than like a clean trial with one drug, one agent. This is a interesting slide that when we look into detail about the PD-L1 status, we found that tumors harbor super high PD-L1, greater than 80%. Actually, those patients' initial response rate are similar if you start with TKI or immunotherapy plus minus chemo. But the frontline PFS, as well as those patients' overall survival, do better with starting with immunotherapy containing regimen. The reverse is actually also true, that if the tumor have a low PD-L1 defined by less than 50%, those patients actually benefit from the blue color that's the TKI upfront. And then the tumor have immune markers in between, those two lines are quite intertwined. So that study, although it's a real-world analysis, but help us to understand maybe in the clinic, we probably not just take NGS as the only biomarker, but rather than taking both into account of the PD-L1 as well as MET exon 14 skipping to help us to sequence the treatment a little better. Moving forward, I want to follow up with Dr. Camidge's discussion about MET being the secondary driver. Here is MET in the osimertinib-resistant patients who had MET amplification as their primary resistant mechanism. Very similar to the MET targeting approach by ADC, here, the dual inhibition of EGFR pathway together with MET pathway actually do give benefit to the patients. This is a study called INSIGHT-2. It's a follow-up study of Vision as well as a INSIGHT-1 study that's a smaller dedicated study in Asia. In this particular analysis, over 100 patients who had EGFR osimertinib progression received testing by ctDNA, and the MET amplification was defined as a high MET amplification. Those patients receive either topotecan monotherapy or topotecan with osimertinib. The observation is actually identical to the Teliso-V's data that Ross was discussing earlier. If you only inhibit the MET-related pathway, it's inadequate. The response rate is less than 10%, very similar to the Teliso-V's data. Only when you do the dual inhibition, patient derive deep and durable response and have the clinical benefit for around 8 or 9 months. This is not just true for topotecan. The paradigm continued to demonstrate the efficacy in Savannah trial. As we discussed earlier, savolitinib is another type 1b MET TKI. In this study, MET IHC instead of amplification copy number was used as a biomarker. Here, Savannah demonstrated a very similar response as demonstrated here by the waterfall plot, around 50% in the high IHC population. Follow-up study is called SACHI, which was reported by Dr. Shen Lu a couple of years ago, demonstrated that this is an Asia-only study showing that osimertinib plus savolitinib is superior to chemotherapy in this patient population. Then let's talk more about the resistance. Not only MET can be the resistant mechanism mediating the EGFR resistance. For MET TKI, secondary resistance to MET TKI can also derive. Overall, the TKI resistance is very similar, classified into MET on-target resistance, bypass pathway activation, and probably lineage-dependent and unknown resistant mechanism. Here is the earlier study showing the spectrum of the 3 different categories. Because we start to learn about MET resistance, we start to look at what are the possibilities to overcome those resistance. Showing on this busy table that type 2 MET inhibitor oftentimes can overcome the type 1b induced resistance, especially the secondary MET resistant mutation itself. However, other resistant mechanism need to be tackled, sometimes maybe using a more ubiquitous rather than specific approach. So in summary, I want to just wrap up together that MET, at least 3 mechanisms can lead to activation and oncogenesis. What we want to we already talked about MET exon 14 skipping at the DNA level, amplification at the DNA level, and overexpression at the cell surface level. And then targeting approach is to a certain degree dependent on the biology. For example, the skipping and amplification, oftentimes they respond better to the TKI approach, and the cell surface oftentimes need an antibody-based approach to target. And currently, we are moving forward with multiple newer generations of targeting approach, like Dr. Camidge was discussing, as well as more general approach from other ADCs.
Thank you. I hope that everyone noticed how often Dr. Lee and Dr. Camidge's names came up in those references. We're really quite lucky to have this group.
Would you like me to
Yes,
lead on? So you remember the patient who you all chose that you were going to give Teliso-V to. So what happened? Well, let's see. What's the follow-up question?
I think the last slide, I think, was, okay, here we go. Do you want to go back to the,
I don't know.
I think
I
the
don't know what-
last slide was to
I don't know what the
ask-
follow-up question was.
I think was to just
What second-line
repeat
treatment
that
would you
question.
What second-line treatment would you recommend and why? I think we already did that.
Well, I think we will have to discuss a little bit about the newer target. So in this particular case, patient also had a concurrent detected KRAS G12D. In light of this year's AACR and as well as ASCO, at certain cancer centers, the patient might benefit from a trial.
Fair enough.
Maybe we'll take a moment just to, we have some interesting questions here. I'll just,
Do you want to do the questions?
yeah, let's
Okay.
do the questions. So, and a lot of these are on these combination therapy questions, so that's why I wanted to do it now. Relevant drug-drug interactions when you're treating with 2 targeted agents, with osimertinib and capmatinib or tepotinib. I generally have not seen combination toxicities. You do, unfortunately, have the toxicities of each agent. Do either of you have other experience?
No, I also find that the combinations are quite safe, in that oftentimes the patient already tolerated osimertinib quite well for a prolonged period of time. And when you add on the MET targeting TKI, it's a different spectrum of different toxicities, mostly edema and some proteinuria and hyperalbuminemia. So I find easy to manage actually for those 2 classes of TKIs.
Yeah, I agree.
Right, and then we have a question about brain metastases. If you have a patient with brain metastases, what's your preferred therapy?
Well, it depends. So if you had somebody who we knew was MET-driven, let's say they were MET exon 14 skip mutant at the beginning, I think there is activity of capmatinib and tepotinib in the brain. In the acquired resistance setting, it's much harder because you don't know what's going on in the brain. You don't know whether it's pharmacokinetic failure. So I think if I was going to say, okay, I biopsied your liver and you have MET amplification, plus you've got new deposits in your brain, I wouldn't automatically assume the brain is going to respond if I add in the MET TKI. Maybe I do it, and if the patient was asymptomatic, I just have a short interval MRI and decide if I needed SRS salvage.
Sounds like good advice. All right, we have another video.
I appreciate that my oncologist treats me as a person. and understands me as a person, understands what my goals in life are, what I like to do, what's important to me. So I'm not just a cancer patient, but I'm a person as well. And so I think that's really important. It's kind of like the bedside manner, and that is really important to patients. My oncologist makes sure that I understand what he's recommending or what he's talking about. He asks if I have questions. I am so grateful for that. And as physicians, your words matter. You are the expert in the room. And so it's important to think about what you're saying to your patients. I've never had an oncologist tell me that I have an expiration date, and I appreciate that. I mean, I can look at the statistics on my own. I know what they are. But I appreciate that there's always hope in the conversations. There's always the next step, what the next plan is. And so that is important. Making sure your patients understand, making sure that you understand your patients, and choosing your words carefully to continue to give hope when there is hope.
Thank you for that. Very, very helpful to bring us back to those thoughts and words. We'll now be going on to another patient case that Ross is going to take us through.
Thank you. This was where I thought I was going to be going earlier. So this is that you've started them on Teliso-V, and they initially respond. And then a few weeks, a few months in, they're feeling fine. Oxygen saturations are fine in the clinic, but the CT scan shows this. You suspect your patient has developed grade 1 interstitial lung disease on treatment with Teliso-V. So you get to decide, what would you recommend? 1, continue treatment, but consider corticosteroids as soon as grade 2 pneumonitis is suspected. Withhold treatment and consider corticosteroids now, resume treatment upon radiographic resolution. 3, permanently discontinue treatment and consider corticosteroids. Or 4, you're still not sure. The standout winner is withhold treatment and consider corticosteroids now, resume treatment upon radiographic resolution. That's certainly what I would do. We'll dig into ILD just a little bit. Can we go back to the slides, please? So I showed you this table before of treatment-related adverse events of special interest for Teliso-V. And if you look on the 1, 2, 3, 4 lines down, the adjudicated ILD rate is about 10%, of which half of which were grade 3. So grade 1 is asymptomatic, radiographic changes only. Grade 2 is symptomatic, grade 3 is requiring oxygen. This is with a different drug. This is with the deruxtecan. I was the co-chair of the ILD adjudication committee for a few years. The median time for onset for this was 5.4 months, so it doesn't always happen early. It's presumably related to cumulative exposure. The issue about adjudication is sometimes people can be misled, and about the time we recategorize something that was put in as drug-related ILD as something else, usually because it was an infection, viral or bacterial, or they had some radiation that was just an evolving radiation change that was misinterpreted. But in general, the key thing is to catch it early. So what I would recommend is that if you have that patient who has what looks like classical ILD on the CT, is I would hold the treatment, I would give steroids, I would wait for it to resolve, and then I would re-challenge. You can decide whether you want to re-challenge at a lower dose. You can decide if you want to re-challenge with steroids on board, but there's potential you can get through it a second time. This one's for you, Jonathan.
So I do think that with our modern agents, interstitial lung disease is probably the biggest challenge. It's across many of the TKIs, nearly all, if not all, of the ADCs. And often the radiographs, as Ross was mentioning, can be challenging. There can be patients that had a viral infection or had patients not on therapy. Sometimes we see some ground glass opacities come and go. But I think we've all come to see that this can go bad quickly, and having being really alert to this possibility. One of the nice factors of ADCs that are working is that the duration of response is often quite long, and skipping a dose or two often has minimal negative impact. So I think in a time of uncertainty, holding drug, I think using steroids to try to accelerate the recovery is often very appropriate. So the alerting patients to be aware of new dyspnea, new cough, monitoring and closely looking at the imaging is quite useful. Sometimes radiologists have different degrees of sensitivity to this issue, so often if you can, looking yourself at the scans I find to be useful. Grade 1, the recommendation is to withhold treatment, consider corticosteroids, and resume treatment upon improvement. And grade 2 or greater in this trial was permanently discontinue. If I treated and it fully resolved and it was a mild grade 2, I might consider restarting, but I think there may be different takes on that. So we talked about this case and like to see it improve and then able to restart. And I do think, while it's hard to do prospective studies of this, I think often early intervention is very likely to get it under control and keep it from being an issue that affects this treatment or future treatments. May have gone 2 slides. Peripheral neuropathy is a frequent issue that Ross did mention briefly. Being aware of it, similarly, dose holds, dose reductions. This is a side effect that can improve over a short period of time, perhaps very different than taxane neuropathy. And often you can have a patient on long-term treatment. I have a patient now getting long breaks in between infusions, 1 to 2 months sometimes, but now on the drug for many years. The other AEs that we talked about, I think have been reviewed, but as Yuning was saying, hypoalbuminemia and peripheral edema can be some of the more refractory ones, often particularly in older patients, and can be dose limiting. Maybe just take a moment to any pearls of wisdom on how you manage peripheral neuropathy?
No, that's the problem. It's very difficult to manage. It doesn't usually respond to diuretics, lymphedema massage, supportive stockings, those sort of things.
All right, I think those are the main ones we wanted to focus on here. There's a follow-up question here that you could take a quick look at, and then we'll move on while you're looking at that. I will, please, the questions have been great. We have a couple more minutes, and I know we all love to take questions. It keeps us focused on what you're interested in, but I can call out a couple of these questions here, beginning with, which treatment would you choose in a patient with MET exon 14 skipping and c-MET overexpression? Yuning?
That's a great question. In fact, I think both for the VISION trial as well as the capmatinib geometry trial, there was a subgroup analysis. So for MET exon 14 skipping patient, around 8 to 10% have concurrent amplification. Those tumors are super sensitive to TKI. They actually are best responders. For if I detect a MET amplification together with exon 14, I'm actually going to incline to start with TKI to derive best efficacy. Similar idea to what Ross was alluding to. If the tumor is very dependent on the pathway, the best approach is to suppress the pathway.
That's great. And now we'll get back to questions of adverse events. Just briefly, how do you discuss those with your patients? What to be on the lookout, what they should call you about, what they should wait for the next clinic visit to talk to you about?
I guess that depends on the agent. I think for the MET-directed TKIs, The biggest thing is the peripheral edema, and that can manifest as unexpected weight gain, particularly rapid weight gain because it's fluid rather than flesh. So I warn people about that. It's particularly problematic in those who are, in the sort of 70s or 80s, because they have a tendency to have sort of vascular insufficiency in the first place. In terms of the other side effects, many of them are laboratory abnormalities. Many of the MET TKIs, for example, artificially increase your creatinine. We didn't mention that, but it sort of interferes with creatinine secretion. If that happens, it classically glows up and then plateaus, so it's not renal damage. It's not going up and up and up, and you just ignore it. And if you want to, you can check cystatin C. I think those are the dominant ones.
Yeah, so for TKI, I think I'm actually not as worried because those things are not is uncomfortable, but also not immediately life-threatening. I was actually very glad we had a dedicated session talking about ILD. Those can be quite difficult to treat, and early detection is very, very important. The other downside is once a patient truly have a grade 2 ILD, oftentimes those patients are excluded from the subsequent clinical trials. So it becomes another layer of challenge. So I usually upfront tell my patients, if you have any feeling of more shortness of breath or even just feel the hypoxia or the hunger of air, so just rush to the emergency room, don't wait.
This is a forward-looking question asking about upcoming and ongoing combination trials with the ADC, Teliso-V in particular. I'm running a trial with Teliso-V and osimertinib. Ross talked about the phase 1 trial, and so now we're expanding to a phase 2 trial. What are some of the ones that you're interested in?
So TMAB-A, the follow-on compound, as we said, is going in a first-line setting, osimertinib plus or minus TMAB-A that Juning is leading. It's also exploring the EGFR wild type in high PD-L1 being added into pembrolizumab. And then it's being explored in the EGFR mutant population, both in expanded data sets as monotherapy and also adding in osimertinib. I think there's a lot of potential for it. I think there's huge potential for it in the driver oncogene subtypes, where we said MET is a common factor of acquired resistance. And I think all of those other MET ADCs in development will be following similar pathways.
Wonderful. I do think one of the special parts of tonight's program has been Maggie's participation and words. We have a few minutes. If we get you a microphone, or am I putting you on the spot? Okay. So, if it's okay that I say this, that I believe that you were on Teliso-V, and
Yes.
would you, from your experience, from the patient experience, we report the numbers, but how did it feel? What was the experience like for you?
So Teliso-V, I mean, it was good initially. I actually had progression on it, so I wish it worked better. The main side effect that I experienced with Teliso-V, and I have EGFR exon 21 and then some MET amplification, overexpression, exon 14 skipping. But so the big side effect for me was the edema that happened again. And then because of that, pleural effusion, which required several thoracentesis procedures. So every 3 weeks, so it was pretty consistent.
So that, as we discussed, unfortunately, a MET toxicity, often perhaps less common with the antibodies and antibody drug conjugates compared to the TKIs, but I think once it begins, it's a challenge to get it under control.
And it could be, I mean, I've had multiple lines of therapy prior to this. I mean, I'd been on capmatinib a couple years before and had the same edema was the side effect. And so, I mean, it could be, you know, that was my 5th line of treatment. So I'm sure that makes a difference as well.
Well, in the last couple seconds, I just want to say thank you for your participation in this. It was great to have the patient experience here. Thank you to everyone who was here, who asked questions. It was really enjoyable for the 3 of us, and we appreciate the opportunity to speak with you. Thank you very much. Thank you. Don't forget to fill out.